Hi, everybody. It looks like we're just getting everyone on. So happy Monday. I think as we're still encountering a little bit of summer slash fall. Hope everyone had a good weekend. So we're going to just give another few seconds to get everyone in. We had over 100 folks registered for today, and the series has been really well received. So just getting folks on. Really super excited to have everyone joining us today. On behalf of the Alliance of Community Health Workers, Patient Navigators, Promotores de Salud, I'm super excited to have what is the kickoff of our series of sessions around sustainability, particularly in this series focusing on reimbursement. And today we're going to have some time to hear from one of my friends and colleagues and someone who I sit with at the national level, and we'll hear more about and from Katie. And then also my colleague, Elsa Staples, who's joining from the Alliance, as well as much of our work at the university. So if you're attending today, you know that we're going to be really focusing on the Center for Medicare and Medicaid, CMS, the PIN codes, the community health integration codes. And Katie's actually going to even have some time to talk about the SDOH reimbursement opportunities and codes too. So if you come to talk about reimbursement, talk about codes, talk about the art of the possible, you have come to the right place. It looks like we now, I'm just waiting for that almost 70 before we get fully into it, but there we are. So hi, everybody. I'm Andy Dwyer. I'm part of the Alliance, part of the National Navigation Roundtable, where I know Katie and colleagues who've been really working on helping inform and really educate about this work, as well as providing some great guidance. We'll have Elsa share a little bit about the Alliance for those who might not be familiar with our work. And I hate to be a total party pooper today, but I'm feeling not well. So I'll get some time to help kick us off. I know we have several of our Alliance members on today, and Elsa will be helping facilitate some discussion as we go through, but really excited about today. So Elsa, I'll turn it over to you and we can talk a little bit about our statewide Alliance.
Thanks so much, Andy, and thank you all for joining us today. We're really excited to kick off this 4-part series. So just a bit of housekeeping before I get going. You all are muted, but there's opportunity to engage in discussion and also ask questions through the chat feature, as well as for specific questions to make sure they don't get lost in the chat, using the Q&A feature, which I believe is available as well. But we'll be monitoring both the chat and the Q&A. This meeting is being recorded, and we'll be sharing both Katie's slides and the recording of this presentation in a follow-up email in the next few days, so you can share with others who aren't able to make it, as well as view again on your own time. So for those of you who are not familiar with the Alliance, the Colorado Alliance of Community Health Workers, Patient Navigators, and Promotores de Salud, we're a pretty volunteer-led small steering committee group, and really here to support all of you across the full state of Colorado in thinking about sustainability of navigation and community health workers, really promote the value and provide resources. And so through that work have had hands in some of the policy efforts, including reimbursement in Colorado and nationally, really making sure there's information about the different programs and training resources for CHWs and patient navigators, and really helping build partnerships and convene like-minded organizations in order to really support reducing barriers to care, all of the important services that patient navigators, community health workers, and promotores provide to the community and through health systems they work in, and really to foster health equity. So if you are not already part of the Alliance, join us. We'll also share in the follow-up email the link to sign up to our newsletter, which is where we share all of our great resources and opportunities.
All right, awesome. Thank you, Elsa. So as we've alluded to, everyone, we're super excited because today is launching the first of a four-part series where we're really going to be focusing on the opportunity for looking at sustainability as it relates to the Medicaid reimbursement, looking at the PIN codes, the CHI codes, and the like for navigation work as it relates, and also the work that really promotes a lot of the community health work integration through CMS. So we're really excited about this offering today with Katie. We're also going to be then moving into early October with the Medicaid reimbursement, and our colleagues from the Healthcare Policy and Finance, Elena Morgan and their team will have an opportunity to talk about the latest and the greatest as it relates to where we are in terms of that SPA implementation and what does it look like for the Medicaid reimbursement. And even I think continuing to get some input and guidance from this committee. So really excited for many of you joining for today's session, but also then hearing at the state level, what are those opportunities for Medicaid reimbursement. Session 3, we're going to be taking some time to really look at those training and development opportunities. And I think this will be great because we look at some of the great resources available in Colorado as it relates to looking at that training, the credential/curriculum opportunities, and how does this really connect with the pieces and parts as relates to being able to bill for Medicare, Medicaid, and then really looking at that professional growth. So we're really excited to have the team from Trailhead, Patty Valverde, PNCT, and that team really also talking about some opportunities, particularly for rural areas for continued resources and support, but at large, looking at what are the workforce and training development opportunities in Colorado to support these reimbursement strategies, but moreover, that network. And then moving in to early November, looking at some of the other ways that we know that people are looking at bundled payments, quality and performance-based payment approaches to look at sustainability of community health and patient navigation work. And I think at that session, we'll also have some time to learn a little bit more about what we're hearing from the commercial and private payers based on some of the work that's been happening in Colorado. So we're super excited about continuing this work. And I will say that, you know, it's a brainchild to make sure that we're doing some level setting, providing our partners an opportunity to share about informing the efforts, as well as really thinking about opportunities to grow the work in Colorado, and really thinking about who do we have in the field who are doing a lot of great work in implementation and helping support, but also even our national leaders and what are we hearing. So we're really excited about this series. And then after the holiday series or the holiday season, I think the Alliance is going to take some time to think about what we're hearing back from all of you, the responses from today, as well as other sessions to continue to build technical support to help with the further implementation of sustainability. Elsa, I'll have you say a few words about the survey that we have out, and then I will introduce the lovely and talented Katie and we'll get underway. But Elsa, you want to share a little bit about the survey that we have?
Sure. So you might have seen in some of the Alliance's recent emails as well. We're currently have a survey out in the field to really better understand the current roles and support needs of community health workers, patient navigators, and promotores in Colorado specifically, both directly from those working in those roles, as well as perspectives from those who are working as supervisors and direct administrators for teams and programs supporting those roles. So if you haven't already completed that survey and you're working either as a CHWPN or as a supervisor of a CHWPN, we'd really love to have you complete the survey. It is a little bit long, so we'll take 20 to 30 minutes to complete, but as a thank you, we are going to select 5 respondents to receive $100 as a token of appreciation. Today is our initial deadline for the survey. We'll see how many responses we have after today, but would really encourage you, if you have a little bit of time today, to please complete the survey. It's in the link. If the link is in the slides, which we'll be sending out, we can also put it in the chat and have sent out through all of the recent Alliance newsletters, including the one that went out today. So we're really looking forward to sharing back with all of you the state of navigation and community health work in Colorado.
Perfect. And one other plug I would just mention is I do think the Alliance, as well as many of the people who are in the field, thought partners in the work, are constantly asked questions related to training needs, support needs, policy initiatives. I would tell all of you that if we could please get as much information back, this will be super helpful in terms of supporting all of us in the field. So I know that it's painful. If I hear anything takes 20 minutes, I'm largely passing over it. But please, 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 if you and your organization could spend time, this would be great, because I think this information could really help further grow the work that we're doing in Colorado. And then continuing, like, really making sure these sort of opportunities are spot on to making sure the needs are met. So fill it out, please. And yes, Greg, great point. I was just trying to do that. I know Elsa will be on it. We'll put that survey link in the chat as follow-up today. We'll go to the next slide because I know I'll introduce Katie. We're going to do a little bit of a pulse check based on where everyone is or isn't in terms of implementing the CMS coding, and just to kind of get a little bit of a vibe. I'm really excited because we're doing this at the national level, that some of the work that Katie's been involved in and others of us. So it'll be great to have a really good opportunity, not just in much of the cancer work that we've done, but also cross sector. I know that there's a lot of people coming from a lot of different settings who are navigating patients from a variety of communities and for a variety of disease types. So I'm super excited to get a sense in Colorado from the Pulse survey, what we're seeing about questions and implementation, especially because we're gathering some of this at the national level. But without further ado, Katie Garfield is the Director of Whole Person Care and a clinical instructor at Harvard Health Law and Policy in the clinical realm in terms of the Center for Health Law and Policy of Innovation, part of Harvard Law School. And I would have to tell you again, Katie has been an amazing collaborator in a lot of the work that we're doing and has really been fantastic in terms of really as a policy leader and as an expert, thinking about how do we make sure that the CMS coding and what we're knowing about the implementation with her and her teams, really moving from that learning opportunity, sharing opportunity, but further thinking about really what we're doing in implementation. And so Katie's actually pulling double duty today because essentially the survey that she largely helped design for the national level is something that we're going to be, again, implementing and getting some response from today. So before, I think, Elsa, do you want to do the polls now? We're going to go ahead and get a little bit of polling information from all of you. And again, Katie, when Elsa kicks it over to you to present, knowing that this is half of your work, because a lot of the polls and the information that we're gathering is based on the leadership and insight of you and several committee members from the National Navigation Roundtable. So Elsa, we'll get the poll started, and then I'll let you then further kick it over to Katie, and I'm going to go off screen. So thank you.
Great. Thank you so much, Andy. I'm going to stop sharing as I launch these polls to give Katie a chance to get her slides pulled up. But I am launching our poll questions now. There are 4 quick questions, so please scroll through using the scroll bar on the right side of the polls in that pop-up. And please answer each of the questions just to get a sense of everyone who's joining us today, as well as where you're at in considering implementation of the CMS PIN codes and the community health integration codes. So I'll give just a couple of minutes for everyone to answer the question. And just got a question in the chat. There are multiple questions, so there is a little scroll bar on the side of the polls where you can scroll through the 4 questions. It looks like we have about 58, 60 responses so far, so I'm going to give it just another 15, 20 seconds, and then we'll go ahead and end the polls.
Also, if someone, because I did this, if someone just hit the one question, I think it might have gone. I don't know if we might need to relaunch or if there's a way, but I don't know that it was clear to scroll down. I don't know if other
I
people.
don't think there is a way to relaunch it while there's still people
Okay.
responding to this round, but
Okay.
appreciate even if you answered one question, that's still
Good
great.
deal.
Okay, it looks like they're trickling off, so I'm going to give it just 5 more seconds and I am going to end the poll and share our responses now. All right, so for those kind of representation of what type of organization people are with today, we have a good number from community-based or nonprofit organizations, academic teaching institutions, and then a mix of other types of clinical facilities from primary care, specialty care, FQHCs, critical access hospitals, and rural health clinics, and then a good number of people who would consider themselves as part of an other type of organization. And then looking at roles, so about 14% representing patient navigators, community health workers, 21% as supervisors, 35% as administrators or leadership, and then another about 15% as billing, finance, couple clinicians, and then some others as well. And then just one person says, 2 people say they're currently implementing, some working towards implementation, a good number considering implementation, and some others not sure at this time yet. And then for a lot of the group, thinking that this would be those in the patient navigator realm or not yet sure which roles of navigators would be implementing these codes. So I think this is really great information to help with framing today, and really appreciate you answering the questions. I'm going to turn it over now to Katie to really kick us off with diving deep into the codes.
Excellent. Thank you so much, Elsa and Andy, for having me here today. And I'll just start by saying what we saw reflected in the poll is very much what we're sort of seeing across the country. These new codes are complicated, and so they're taking a while to sort of stand up. But we are sort of seeing that same trend of we have some small number of front runners out there that have already got them underway, which is fantastic. But a lot of folks are still trying to figure this out. How do we put these in place? What are we going to do? And so really that's part of my role here today, which is just providing some education and answering some questions on how these codes work. What did the federal government say about them, to try and help you on that path towards implementation. But before we get into those codes, let's just start by taking a step back and locating what part of the US health insurance system we're talking about today. So as I'm sure you all know, in the United States, we have really a patchwork of programs providing health insurance coverage. This means that how you receive coverage will depend on a number of factors like your income, your age, your employment. At a high level, we have 2 big buckets of insurance. We have public health insurance, in which a government agency provides your healthcare coverage. And then we have private health insurance, in which private entities like employers provide your healthcare coverage. Then within these 2 broad buckets, we have a range of specific types of insurance. So within our public insurance bucket, for example, we have programs like Medicaid, which primarily serves low-income individuals and families, and the Veterans Health Administration, which serves certain veterans. And then on the private side, we similarly have employer-sponsored coverage and directly purchased coverage. Today, we'll really be focused on new policies that impact payment for patient navigators and community health worker services within one bucket of public health insurance, and that is Medicare. As Andy mentioned earlier, many of you are coming from Colorado. You are very lucky in that you have opportunities across multiple buckets due to the great policy work happening in your Medicaid program. But for today's purposes, we're not focused on Medicaid, we're focused on Medicare as an opportunity. So just a quick reminder, just level setting, what is Medicare? Medicare is our public health insurance program serving individuals who are 65 and older, and some younger individuals who are living with disabilities or certain chronic conditions such as end-stage renal disease. Under federal law, Medicare is broken into 4 parts. Medicare Part A, which is hospital or inpatient services, Medicare Part B, which is medical or outpatient services, Medicare Part C, which is also known as Medicare Advantage, and is a program in which private health plans administer Medicare Part A and B benefits, and then Medicare Part D, which is prescription drug coverage. Today, we'll be talking about a recent change that allows patient navigators and community health workers to have their services billed as part of Medicare Part B. And I'll note, of course, that because Medicare Advantage includes Part A and Part B services, this also has implications for Medicare Part C. So what is this important change that occurred? Well, it was a new rulemaking, so a change to federal regulations that govern the Medicare program. The rulemaking was part of an update to what's called the Medicare Physician Fee Schedule. The Medicare Physician Fee Schedule is a document that describes how the Centers for Medicare and Medicaid Services, the federal agency that operates our Medicare program. The Physician Fee Schedule explains how CMS pays physicians and other enrolled healthcare providers for services provided under Medicare Part B. Again, that's the section of Medicare that pays for outpatient services. The Physician Fee Schedule lists more than 10,000 unique service codes. So there's a huge number of codes. We're really only talking about a couple today. These codes are essentially a shorthand way to describe specific services that physicians and non-physician practitioners can bill for in the Medicare program. The Physician Fee Schedule also outlines the amount that CMS will pay for these services. To do this, CMS uses a system of RVUs, or relative value units, which can be used to calculate payment rates specific to where you're operating. Each year, CMS uses the rulemaking process, so that regulatory process, to update this list, this Physician Fee Schedule. So that means that each year, CMS may add new services to that list, allowing new coverage, as we'll talk about today, or alter key points about existing services. Excitingly, last year's update to the Physician Fee Schedule created new billing codes that can assist in reimbursing and sustaining community health worker and patient navigation services. The new rulemaking happened in several steps. First, CMS released a proposed rule where it introduced the idea of these new codes in July 2023. It then solicited comments on those proposals over the summer and early fall, and it released the final rule last November. The final rule was then implemented on January 1st, 2024, so the start of this year, meaning that these new billing codes are now live for physicians and practitioners that bill Medicare Part B, as shown by the fact that some of you are already billing for them. Notably, this rulemaking happens every year. So this means that each year there's an opportunity for healthcare providers and others to ask CMS to adjust the codes based upon their experience on the ground. So CMS is really taking a big swing by creating these new billing codes, but I think we all know it'll be an iterative process. And so as you engage with these codes, it's really important to think about your experience and lift up your experience, either directly to CMS as part of this comment process that actually just occurred for this year and will happen again next summer, or lift up your experiences to other entities that commonly do that kind of commenting, like the NNRT. Okay, so what does, oopsie, too far. So what does the rule do? It establishes new billing codes for a spectrum of services, including some related to patient navigation. These services may be billed when reasonable and necessary to diagnose or treat the patient. This slide really briefly summarizes those relevant services and the codes that a Medicare provider would use to seek payment. As you can see, the rule really created 3 new buckets of codes that respond in some way to health-related social needs. So these include principal illness navigation, which includes both regular principal illness navigation or PIN services, and a separate set of codes for peer support PIN services. It also created community health integration services or CHI services, and then codes for social determinants of health risk assessment. I'll go through each of those buckets on the webinar today. And for more information, I do recommend that you visit the link at the bottom of this page, which takes you to a CMS MLN Matters document that gives a really nice quick breakdown of each of these codes. So like your high level takeaways, if you were taking notes on this webinar today, a lot of that will already be captured in this document that CMS provides on its website. So let's start by taking a deep dive into the principal illness navigation or PIN codes. We'll then shift gears to talk about community health integration and social determinant of health risk assessment. So first, let's look at the 3 core elements of PIN codes. Who is eligible to receive PIN services, what PIN services can look like, and who can deliver them. I'll walk through each of those at a high level, starting with who may receive PIN services. So to be eligible to receive PIN services, the patient must first be enrolled in Medicare. Again, the physician fee schedule is specific to the Medicare program. 2, have a serious high-risk condition. So this is really critical. And CMS defines a serious high-risk condition as a condition that is expected to last at least 3 months, that places the patient at significant risk of hospitalization, nursing home placement, acute exacerbation/decomposition, functional decline, or death, that requires a disease-specific care plan and may require frequent adjustment in medication or treatment regimen or substantial assistance from a caregiver. And I know that's kind of a complicated multi-pronged standard, but CMS helpfully provides examples of some of the types of conditions that are likely to qualify. So for example, CMS states that cancer, COPD, congestive heart failure, dementia, HIV/AIDS, severe mental illness, and substance use disorder could all qualify as a serious high-risk condition. And notably, CMS recognizes in the rule, in its rulemaking, that providers may identify someone who has a serious high-risk condition weeks or even months before they have a definitive diagnosis. And that's important, right? Because it dictates when is that starting point for when you can start billing for navigation services for these individuals. So CMS does not require a definitive diagnosis in order to start applying these PIN codes. Instead, they just require that the billing practitioner is able to determine that a patient has a high-risk condition and therefore qualifies for PIN. For example, a practitioner could find that a patient has a large mass in their abdomen that is placing them at significant risk and could decide on that basis that they have a serious high-risk condition, even if they did not yet know the exact type and stage of cancer that the patient was experiencing. So that bumps that sort of timeline forward a little bit and really relies on the decision-making of that billing practitioner. Next, the rule lays out what PIN services can look like. The rule describes the scope of PIN services broadly, outlining 9 categories of service elements that would be eligible for reimbursement as part of PIN. And those categories are summarized here on this slide. Again, there's more detail in that MLN Matters document if you want to understand what they mean by each of these categories. These are things like person-centered assessment, identifying and referring the patient or caregiver to appropriate supportive services, providing health education, helping the patient with healthcare access and health system navigation, facilitating and providing social and emotional support. All of these things are service elements that are allowable under the PIN services. And again, as you see noted at the bottom of this slide, it's important to note that CMS does distinguish between regular PIN services and PIN services provided by peer support specialists for behavioral health conditions. I'm really focusing on in this presentation on those regular PIN services, but I'm going to try and call out a few places where those peer support codes differ. For example, the service elements do differ slightly for peer supports, and you can see the details of those elements again and how they differ in that MLN Matters document. So third, who can provide PIN services? The rule states that PIN services are provided by certified or trained auxiliary personnel under the direction of a physician or other practitioner, including a patient navigator or certified peer specialist. Again, let's unpack that a little because CMS is good at sort of getting a bunch of key points in one sentence. So first, CMS explicitly recognizes that PIN services may be provided by patient navigators. That's a big win. And patient navigators would be considered auxiliary personnel. This is an important distinction because these codes use what's called incident to billing, and we'll talk about that more in a bit. Second, those patient navigators must be operating under the direction, here defined as general supervision, of a physician or practitioner. This means that the patient navigator who provides PIN services must be under the overall direction and control of a physician or practitioner who's billing Medicare, but that practitioner does not need to be physically present while the navigator provides the services. And furthermore, the rule states that these patient navigators don't even have to be on staff at the billing practitioner's organization. A physician or practitioner who's billing for Medicare may contract with an outside entity, like a community-based organization, to provide PIN services. If they do so, though, they must make sure there's still that clinical integration with those entities. That means there has to be sort of an ongoing communication between the practitioner and the individuals at the community-based organization who are providing services. So think of it as like a feedback loop about the provision of these services. And finally, individuals providing PIN services must be certified or trained. CMS is again broad in defining what it means by certified or trained. They acknowledge that some states have specific certification or licensure program for auxiliary personnel like patient navigators. In those states, the auxiliary personnel, so the people providing the navigation services, must meet those state-defined requirements. However, CMS also recognized that many states do not have a certification program or licensing for these auxiliary roles. In those states, CMS says that individuals providing these PIN services must simply be trained to deliver all of the service elements, so all those categories of services on the previous slide, and that such training must include certain core competencies which are outlined on this slide. The one exception to this broad, flexible approach is for those PIN peer support services. If no certification system exists for peer supports in a given state, CMS requires training to be consistent with the National Model Standards for Peer Support Certification published by SAMHSA. And again, you can see these training competency categories are pretty broad. There are things like patient and family communication, interpersonal and relationship building, patient and family capacity building, service coordination, and systems navigation. As you can see, you have the full list here. It's also in that MLN Matters document. And I'll just note here, for incident to services, it's the billing practitioner's responsibility to ensure that all payment rules, including training criteria, are met. So that that person who is billing for the services has to, it's their responsibility to ensure that their team, their patient navigators, are trained. So in addition to establishing who may receive the services, what the services look like, and who can provide them, the physician fee schedule rule also provides information about the process of delivering these PIN services. This is why we've heard a lot of feedback around workflows because programs are having to shift their workflow slightly in order to bill for these services in order to align with the process CMS outlines. So the key elements of that process are outlined on this slide. And I'll note that CMS has applied a very, very similar approach for community health integration services or CHI services, which we'll talk about in a moment. So we're just going to walk through that process step by step, beginning with the initiating visit. So before PIN services can begin or be billed, there must be an initiating visit with the patient. This visit must be conducted by the physician or practitioner who's going to be billing for the PIN services. And the goal of this initiating visit is really to establish the treatment plan and specify how PIN services would help to accomplish that plan and establish the PIN services as incident to that billing practitioner service. So again, this is incident to, so you have that Medicare enrolled provider, physician, et cetera, who's actually going to bill for the services. So the initiating visit really has to start with that individual where you're establishing a treatment plan, and then these services are allowed to be billed as incident to that provider because they're really just fulfilling the plan that that individual has laid out. So that's what we mean when we say sort of incident to. In the final rule, CMS outlines 3 specific types of visits that can qualify as an initiating visit for PIN services. First, evaluation and management visits other than a low-level visit that can be performed by clinical staff. Second, an annual wellness visit when furnished by a practitioner who identified in that wellness visit a high-risk condition that could qualify for PIN services. And third, 2 types of visits that play a similar evaluation and management role for clinical psychologists, which are psychiatric diagnostic evaluation and visits involving health behavior assessment and intervention services. Notably, this initiating visit does not need to occur every month that services are received. It must just occur once before starting the PIN services and then must be repeated once each year. In addition to conducting that initiating visit, the provider also has to obtain patient consent before delivering these PIN services. Again, there's flexibility on how this happens. The consent can be obtained by the auxiliary personnel, so the navigator can obtain the consent, and it can be written or verbal. The consent must be documented in the medical record, and it must explain that there will be cost sharing for PIN services. Similar to the initiating visit, this consent doesn't have to happen every time PIN services are provided. It just has to happen once before beginning delivery of PIN services, and then again, reobtained on an annual basis. Once consent is obtained, the auxiliary personnel may provide those PIN services to address the patient's needs in accordance with that treatment plan. As a reminder, the PIN services fall into 9 broad categories, which I've repeated here on this slide. So once the services have actually been provided, they then have to be documented in the medical record. So notably, while the services themselves may be provided by auxiliary personnel, so navigators, it is ultimately the billing physician or practitioner who is ultimately responsible for documentation. Though CMS notes it does allow others, like community-based organizations, to create the record, but the billing practitioner really has to review and approve it. So specifically, that billing practitioner has to document first the time spent providing PIN services, second, the activities performed by the auxiliary personnel, third, how the activities related to the treatment plan, and fourth, any social determinants of health needs that were identified as part of this process, if any. And then finally, the billing physician or practitioner actually gets to bill for the services. Again, the billing practitioner accounts for the time spent by auxiliary personnel by billing it as incident to their services. To do so, the physician or practitioner will use the new codes outlined in the physician fee schedule rule. The codes are summarized here on this slide. As you can see, the first 60 minutes of those navigation services are billed using the code G0023. And then after that, each additional 30 minutes is billed using a different code, G0024. And there is no limit on the use of that add-on code. So you can bill 60 minutes up front, and then if you provide multiple 30-minute increments after that, you can use that add-on code multiple times. So for example, if a patient navigator provides 2 hours of PIN services for a patient in a given month, the billing practitioner would be billing using G0023 for that first hour, and then would bill G0024 twice to account for the second hour. The billing practitioner would take a similar approach for PIN peer support when serving patients that are receiving services based on a behavioral health condition. They would just use different codes, but they operate the same. So they would bill G0140 for the first hour of PIN peer support services, and then G0146 for each additional 30-minute increment thereafter for PIN peer support services. Notably, physicians and practitioners in FQHCs or rural health centers would use a different approach. Their CMS expanded the scope of a code that is G0511, and that's a code for general care management. So it allows FQHCs and rural health centers to bill separately for this service. Again, FQHCs and rural health centers can bill this code multiple times in a given month as long as the requirements are met each time. And finally, I think it's important to note that the final rule does not place a practitioner limit on PIN services. CMS acknowledges that it's feasible for people to be receiving PIN services from multiple places at one time if they're navigating multiple conditions. And so CMS allows one practitioner per condition to bill for PIN services per month. So, for example, one practitioner can bill for PIN services for a patient's cancer per month. You can't have multiple practitioners both billing for cancer navigation, but if that same patient has needs PIN services both for cancer and for diabetes, and there are 2 different billing practitioners for that, that's allowable. Okay, so let's shift gears and talk about the second new set of codes. These are called community health integration services. Notably, a lot of what I just said about PIN services applies to these CHI services as well, because CMS has really taken a parallel approach on these 2 categories of services. And so while I'll walk through the whole process again, I'm going to try and do so a little more rapidly because a lot of this is repeat, and I'll particularly try to call out places where the codes differ. First, the main difference between these services is eligibility, so who these services are designed to reach. As you'll remember, PIN services are really designed for Medicare patients that have a serious high-risk condition. In contrast, Medicare enrollees do not need to have a serious high-risk condition to receive CHI services. Instead, they must simply have a social determinant of health need, such as food insecurity, transportation insecurity, housing instability, that is significantly limiting the Medicare practitioner's ability to diagnose or treat the patient's medical problem. This focus on social determinants of health is in some ways a defining feature of these CHI services and on some of the differences between CHI and PIN. Also note, CMS specifically notes that patients can't be under a home health plan of care under Medicare Part B while receiving CHI services, that there would be too much overlap. So what do the services look like? Like PIN, CMS describes the scope of these CHI services within broad categories. Here there are 8 categories. They are by and large the same as those for PIN services. You again see things like person-centered assessment, practitioner home and community-based care coordination, and health education. However, in some of these categories, when you go to that MLN Matters document and see the detail, you'll notice that there's added attention to addressing the identified social determinant of health need. In contrast, CMS acknowledges that addressing social determinants of health may be a part of PIN services, but it also may not be, depending on the needs of that individual patient. In contrast, CHI really focused on social determinants of health. For example, where both PIN services and CHI services include a person-centered assessment, However, for PIN services, CMS describes the purposes of this assessment as to better understand the individual context of the serious high-risk condition. In contrast, for CHI services, the goal is to better understand the individualized context of the intersection between the social determinant of health need and the problems addressed in the initiating visit. So again, that emphasis on SDOH. Let's now look at who can provide CHI services. So CHI services are provided by certified or trained auxiliary personnel, including a community health worker, under the direction of a physician or other practitioner. As you can see, the framework around who may provide CHI services is almost exactly the same as PIN services. The example just really changes from patient navigator to community health worker. As with PIN services, the auxiliary personnel providing CHI must be operating under the direction, again, which means general supervision of a physician or practitioner. So again, that means they must be under overall direction and control of the billing physician or practitioner, but that practitioner does not need to be physically present while CHW services are being provided. And again, these auxiliary personnel or community health workers don't even have to be on staff at that billing practitioner's organization. The billing practitioner can contract with an outside entity like a community-based organization to provide CHI services as long as there is that clinical integration. And as with PIN codes, individuals providing CHI services must be certified or trained. Again, CMS is broad in what it means by certified or trained. As with navigators, people providing CHI services must be certified or trained to perform all the service elements and authorized to perform them under state laws and regulations. Again, CMS acknowledges that some states have specific certification or licensure programs for relevant auxiliary personnel like community health workers. In those states, auxiliary personnel must meet those state requirements. However, CMS also recognizes that many states still lack certification programs. In those states, CMS says that individuals providing CHI services must simply be trained on certain core competencies, which are described on this slide, and again, are similar to those for PIN services. Additionally, as with PIN services, CMS provides details not only who can receive and provide CHI services, but also on that process, that workflow that has to be in place and documented. The key elements of that process are the same as for PIN services, with some slight changes in the details on some of the individual steps. Again, before CHI services begin, the billing practitioner has to conduct that initiating visit. The visit must be conducted by a physician or practitioner who will then be billing for the services. And that goal, again, is to establish the treatment plan. You have to specify how addressing that unmet social determinant of health needs would help to accomplish that plan and establish the CHI services as incident to the billing practitioner service. In the final version of the rule, CMS outlines 2 specific types of visits that can qualify as an initiating service for CHI. First, evaluation and management visit, other than a low-level visit that can be performed by clinical staff, including E&M visits that are provided as part of transitional care management. And second, the annual wellness visit. Notably, CMS chose not to allow those psychiatric, diagnostic, and health behavioral assessment visits to be initiating visits for CHI services. So that's a difference between PIN and CHI. And notably, this initiating visit, again, doesn't have to occur every month that services are received. It just has to occur once before starting CHI services. As with PIN services, CMS also requires patient consent here. Again, there's flexibility on how it happens. It can be obtained by auxiliary personnel, so it could be obtained by a community health worker. It can be written or verbal, and the consent must be documented in the patient medical record, and it must include a discussion of the fact that there may be cost sharing for these services. There are a few small differences, though, where PIN services require consent to be reobtained annually. You don't have to reobtain consent for CHI services unless the practitioner who's billing for those services changes. Also, unlike PIN services, CHI services can only be provided and billed by one practitioner per month. So you'll remember PIN services, you could have multiple people billing for it as long as it was for different conditions. Here for CHI services, you can only have one practitioner bill for it per month. So if another practitioner tries to bill for it, that'll get denied, right? It'll just be that first person to submit for it. Once consent is obtained, the auxiliary personnel can provide the services to address the social determinant of health needs in accordance with the treatment plan. Again, those fall in the 8 categories described on this slide. And once services have been provided, they have to be documented in the medical record. Like PIN services, while the services themselves can be provided by those auxiliary personnel, the billing practitioner is ultimately responsible for documentation. But again, CMS allows others to create the record as long as the billing practitioner reviews and improves it. And specifically, the billing practitioner must document first the time spent providing CHI services, these are time-based codes, 2, the activities performed by the auxiliary personnel, and 3, what social determinant of health needs are being addressed. You can use ICD-10 Z codes, those ICD-10 codes that are used for social determinants of health. CMS doesn't require it, but you can. You just have to document the social determinants of health in some way. And finally, that billing physician or practitioner must bill for services. To do so, the billing practitioner will use the codes outlined in the physician fee schedule rule, which are summarized here on this slide. And they operate much the same as the PIN codes with that 60-minute code to start and then an add-on code for each additional 30-minute per calendar month. As with PIN services, that add-on code can be billed multiple times and there's no frequency limit. Notably, as with PIN services, physicians and practitioners in FQHCs and rural health centers will again use a different approach. There, CMS expands the scope of G0511, that general care management code, allowing the FQHCs and rural health centers to bill separately for this service. And again, it can be billed multiple times in a given month as long as the requirements are met each time. And finally, I think it's important to note that unlike for PIN services, CMS has imposed a practitioner limit for CHI services. As I mentioned before, only one practitioner may bill for CHI services in a given month. CMS states that is to help ensure a single point of contact for addressing social needs that may span other healthcare needs. So trying to avoid fragmentation, duplication. Okay, I know that's a lot. I'll just really briefly talk about social determinants of health risk assessment, but we've made it through the bulk of what we're covering today. So this is a final new code, and it's for social determinants of health risk assessment. So who can receive this service? Medicare enrollees, so you have to be enrolled in Medicare, and the billing practitioner must have reason to believe that the patient has unmet social determinant of health needs that are interfering with their ability to diagnose or treat a condition or illness or will influence choice of treatment or plan of care. So this is a really important distinction CMS makes in the regulation. This is not really meant to be a code for routine screening for social determinants of health. Instead, CMS is pretty explicit that it's about identifying social determinant of health needs when you already have reason to believe they exist and that they're going to interfere with diagnosis and treatment. Okay, so what can this risk assessment look like? First, it's important to note that CMS has not blessed a particular screening tool. Instead, CMS allows the practitioner to use any standardized evidence-based social determinant of health risk assessment tool that includes food insecurity, housing insecurity, transportation needs, and utility difficulties. So for example, a lot of common tools would qualify. CMS Accountable Health Communities tool, the Prepare tool, both of those would qualify here. This assessment can occur in person or via telehealth, and it has to be then documented in their medical record. And when can it occur? CMS does place a time limit on this code. Each practitioner can only use this code no more than every 6 months per beneficiary. And the assessment can occur in conjunction with certain types of visits, including evaluation and management visits, behavioral health office visits, or the annual wellness visit. Again, the assessment does not have to occur on the same date as the relevant visit, though CMS says it expects that will typically be the case. And then last but not least, the actual billing. So here you can see the code that you would use, G0136, to bill for this assessment. It's expected to take 5 to 15 minutes, and again, can't occur more than every 6 months. And notably, CMS has said it will provide some further sub-regulatory guidance on billing for this in FQHCs and rural health centers. But the initial rule notes that these settings can bill for the annual wellness visit, and the assessment is an optional element of that visit. Okay, so that's a lot. But importantly, I don't think you have to walk away from this webinar with all the answers. I'm just hoping that this presentation either introduced or reinforced or clarified some key concepts and processes associated with these new codes. Then you can always go back and turn back to these slides or online resources that provide you more information. This last slide provides some of the resources that I go to the most. So again, that MLN Matters document. CMS has also put out a useful frequently asked questions document on this, which you can see here. I also forgot to put on here, I should have, NNRT also has an FAQ on their website that explains some common questions. If you really want to get in the weeds, there's the link to the actual federal rule. And then our center on our health law lab also provide some additional materials that may be helpful on certain questions related to this. So for example, we get a lot of questions about that cost sharing requirement. We actually created sort of a short FAQ on that particular issue to help people understand what the requirement is, the supports that many patients may have in place to actually take care of that cost sharing, and then what to do if a patient is unable to pay the cost sharing. So all of that is available on our health law lab. Okay, so I think that's everything. Let me stop share. Again, I know that's a lot of info, so thank you all for bearing with me. And like I said, oh, it looks like Elsa has dropped all of those links in the chat, which is fantastic. Thank you, Elsa.
Of course. And yes, they will be on the slides, which we'll send in the follow-up email as well. So if you lose the link from today, you'll get it again. But yeah, thank you so much, Katie. Does anyone have any immediate questions for Katie? I don't think I've seen any come through the chat yet, but just want to make sure.
Also, I'll have this because I think Becky from the State Health Department and is a partner in our work. I think Elena and team are going to be talking about Medicaid next round, and then Becky's team at the State Health Department has really been putting in a lot of time to think through all of the pieces that we talked about around that training, the certification / credential, whatever the name lands. So I know Becky's going to be sharing some information, I think, in the chat, but that's something that we'll be able to feature additional partners sharing some of those intricacies of what this really means in implementation in Colorado. So just want to say this is really great information, and you know, it's the first of one series for subject matter experts to join, but we will continue to be building off of this work. And would just also say if there's others on the call who have additional resources or information, it's something that we'd love to share as well. So thanks for Becky and the health department for being on. And I know there'll be a great resource as we implement this, and so excited for the leadership from many of our state institutions. But sorry, Katie, not to cut you off, but that is fantastic. And I got to tell you, every time you present, even when I don't feel well, I learn something new. So this is fantastic.
And one resource I also want to flag that I realized I didn't mention about that cost sharing requirement, which is something that we've heard a lot of concern about, obviously, because many of the people who most need patient navigation may be least able to pay a cost sharing amount. I just wanted to flag that the Patient Advocate Foundation has been doing some really amazing work to create sort of a relief fund to help those patients. So I'm just going to look that up and drop their link as well, because that's a really, really helpful resource for anyone who runs into that issue.
Thanks, Katie. Yes, I think that has come up a lot as a concern and question from other conversations. So really wonderful that there is a resource in place to help with that. And then Beverly, I know, has her hand up, so we can go to Beverly next for a question. And Beverly, you're welcome to come off mute.
Thank you. I know at the beginning you mentioned that we're focusing on Medicare. At some point, will there be more information or distinction between Medicare and Medicaid billing for these services?
So yes, I think first I'll note, as Andy mentioned at the start, right, I think the next session will focus on Medicaid. So you'll get to hear the comparison there. And so it's gonna, on the Medicaid side, it's gonna depend on the rules set up at the state level in Colorado, for example, around what billing might look like there. And so it'll be interesting to see how that ends up aligning or not aligning with the way that these are paid for, as we know that could create implementation hurdles for programs trying to do both.
Okay.
And I'll see if Elsa or Andy want to say anything more there.
No, we'll be getting into the detail in number 2, and then Becky has put in a little bit further about the work that's happening around in the chat around the leadership from the state health department, who will really be helping implement as one of our agencies who's helping support this work. So I know Becky and team are really looking at all of the strategies to make sure that we're really looking at existing workforce, how to support that, as well as new opportunities. So huge thanks, and we'll continue to share that information as it becomes available, and hopefully feature Becky and CDPHE team as we continue to have these updates and the like. But yeah, Beverly better be coming back for number 2. So we'll be on the lookout for you.
Yeah.
All right, I will. Thank you.
And I'll say thank you for doing, all of that great work to Becky in the chat there. That's going to be really important for that point about training, right? Remember, I made that distinction of how the auxiliary personnel have to be trained. If there is a straight state credentialing system, CMS will require those auxiliary personnel to meet those state requirements. So the work that sounds like it's happening on the ground in Colorado will be really important to setting that bar for your state.
And I think this might be a really great time to do our second pulse check, which is after hearing all of these details of the PIN and CHI and social determinants of health codes, what you all feel like might be the challenges, as well as some of the benefits for those codes. And I think that might help us with framing future technical assistance, as well as thinking about any other questions you all might have. So I'm going to go ahead and launch the second round of polls. This one has 3 questions, so please scroll down and answer the 3 questions before you submit your responses. And if you have other questions or resources for Katie, go ahead and keep putting those in the chat as we're also getting responses to the polls.
Oh, and I see someone asking, are the PIN and other codes relevant for Medicaid? So right now they are definitely relevant for Medicare. Whether or not they're relevant for Medicaid is going to depend on how Colorado decides to set up its billing around patient navigation and community health workers. They could use the same billing codes. It will be up to the state ultimately to decide how it's going to approach that. So more information to come on that, I believe.
And Elena Kelly from HICPUF in Colorado is on the call today, but we'll be walking through those codes in our session 2. So we'll be doing a similar type of presentation in session 2, which is kind of where they're at with development of those codes, and I think even possibly a preview of what they might look like. So lots of details to come in that session, and I think that'll be really helpful for compare and contrast. Okay, I'm still getting, looks like 1 or 2 more responses just came in, so I'm gonna give it another 5-10 seconds, and then I'm gonna stop this poll. I think we are good with receiving responses. Okay, I'm gonna stop and share the results. So for what people expect to be the largest challenges, it looks like all of these types of challenges look like they may be come into play for each of you. So everything from the reimbursement rates and out-of-patient costs, but particularly the administrative burden, I think rose to the top as the most commonly selected. Workflow challenges, and then just since they're so new, trying to figure out exactly how to put all the pieces all together for implementation, as well as the training and staffing components as well. So every single challenge there got a response. And then thinking about the benefits, improved patient outcomes really rising to the top there. The income for the navigation workforce, and really being able to hire more navigators or start a navigator program. And then all of the satisfaction from the navigator side, patients and providers, and buy-in. And then lastly, other types of reimbursement organizations would be interested in reimbursement through Medicaid. 91% said yes to that, then private insurance, and then some of those other models as well. So thank you all for responding to the polls, and Katie, turn it back over to you if you have anything you want to share based on those responses.
So, I think, first of all, thank you all for those responses. I think they're similar to sort of what we've been seeing at the national level, concerns around the cost sharing piece, around reimbursement, and particularly just around like workflow and how do we do this. At least on that. So my recommendations on those are, one, on the cost sharing piece, take a look at the Patient Advocate Foundation resource. Also look at that FAQ on copays that I provided earlier in the chat. It gives you a really nice outline of like the different ways that cost sharing might get paid. That's really helpful. And then on sort of how do these things get implemented, I think we really need to start looking to our early implementers. I think the most helpful next step that we as a field can have is having those organizations that are doing this already speaking up and sharing their experience. We did that at the National Navigation Roundtables meeting a couple of weeks ago, and it was tremendously helpful and sort of demystifying and saying like, this is possible. You just have to start. And I think hearing those examples is tremendously helpful. I see a couple of questions in the chat. How does the provider substantiate that social determinant screening is warranted? Many providers are including screeners as part of their intake process for all patients. Yes, I think this is the trickiest part of that social determinant of health risk assessment. You're right that a lot of providers are already doing just a standard screener for everyone. And the one sort of tricky piece to that risk assessment code is it's not really meant for that sort of standard across the board screener. CMS really describes it as a situation in which you have reason to believe that the patient has a social determinant of health barrier. And it gives a couple of examples that sort of illustrate this. One example would be a patient indicates that they can only do appointments at certain times due to like a transportation barrier or work hours. It's essentially they are sort of saying the patient says something to you that sort of tips you off that you need to do a deeper assessment because there may be social determinant barriers in place that you need to understand more fully. And I completely understand and sympathize with the fact that that feels like a very tricky standard because so many programs are really just doing a social determinant of health screener. I think that's a good point to get engaged on the comment process to CMS about, because if that doesn't work for you, CMS needs to hear that loud and clear and come up with a workaround or a solution, or make a change. But that is how how it stands right now for that code. So I don't have a good answer on that other than speak up to CMS. And then since all the work done by a CHW must be done under a physician, will the physician's liability be impacted? So this is a good question. And I would sort of look, I would go to your organization and sort of talk to your general counsel or whomever to see if there are any concerns here. I will note that this idea of incident to billing is not a brand new thing with these codes. It's CMS for a long time has recognized that a lot of care providers operate in teams. And so they have allowed this sort of incident to system. And so it's very possible that your organization has already done a lot of thinking about this. And so I can't speak to your individual situation, but I do think it's a reasonable question to ask sort of the powers that be at your organization in case there's any added steps they want to take as a result. Oh, and one last thing I'll say, because this came up earlier in some direct back and forth questions. Somebody had reached out about other resources that may be out there, templates and things on how to approach these codes. I highly recommend anything put out by the Partnership to Align Social Care. They've been doing a lot of great work in providing resources and helpful materials, particularly around the CHI codes. But a lot of that, you know, as you can see, there's a lot of overlap, so they may be sort of helpful across the board. So I recommend going to CMS, to NNRT, and to Partnership to Align Social Care, all as great places for more information.
Great. Thank you so much, Katie. That does lead us to the end of our time today. I feel like we could talk about this for a full other hour easily, but I hope this was a helpful introduction to the codes, maybe at a deeper level than you've seen before. And we can also share Katie's contact information if you have any additional questions that come up that aren't answered in some of those other resources. But really, really appreciate you all joining today. Katie for making the time. And we are going to keep these conversations going throughout the series and as we develop other technical assistance sessions. So yes, hope to see you at our next session, and we'll be in touch soon with the slides and resources. I hope you all have a wonderful rest of your day and take care, everyone.
Thank you all.